Hello, dear students, welcome to our program. Today we are going to discuss biochemical analysis of body fluids, and in today's topic we will discuss saliva and cerebrospinal fluid, specimen collection and processing. The main objectives of today's lecture are to get acquainted about various body fluids, to know the composition of saliva, to know the composition of cerebral spinal fluid, to have knowledge about the various biochemical tests of saliva and CSF. First, let's have introduction. Body fluid, bodily fluids or biofluids are liquids originating from inside the bodies of living people. They include fluids that are excreted or secreted from the body and body water that normally is not. The dominating content of body fluids is body water. Approximately 60 to 65% of body water is contained within the cells in intracellular fluid, with the other 35 to 40% of the body water contained outside the cells in extracellular fluid. This fluid component outside the cells includes the fluid between the cells, interstitial fluid, lymph and blood. There are approximately 6 to 10 liters of lymph in the body compared to 3.5 to 5 liters of blood. Dear students, let's first discuss saliva. Physiology of saliva. Whole saliva is a mixture of oral fluids including salivary gland secretions, cellular material and food debris. Saliva also contains molecules normally found in serum that reach the saliva by several mechanisms like intracellular routes include passive diffusion, while extracellular routes include ultrafiltration at tight junctions between the cells. Pathology. Saliva may be affected directly by systemic diseases or may reflect changes in serum concentrations of certain analytes. A reduction in salivary secretions is seen in Jorgen's syndrome, while other conditions like malignancy, infection, endocrinopathies allow biomarkers to be identified and thus aid diagnosis of disease. Exogenous substances such as drugs can also be identified and measured in saliva. Now discussing diagnostic use. The primary uses of saliva testing are in the areas of toxicology, endocrinology and infection. Advantages of using saliva include ease of collection, particularly when such collection requires supervision and storage. Saliva collection is also non-invasive and stress-free, which may be used in pediatrics and in the measurement of stress-affected hormones such as cortisol. Disadvantages of saliva analysis include the low levels of analytes present compared to serum, contamination from the oral cavity before collection, and viscosity of the fluid. Collection may also be difficult in dehydrated patients. Dear students, now let's discuss biochemical tests, endogenous analytes. Infectious disease. Antibody detection includes Helicobacter pylori, Lyme disease, mumps and measles. Viral particles may be measured by PCR. HIV-1 antibodies are particularly suited to salivary testing due to the non-invasive method of sample collection, reducing the risk of infection for healthcare staff. Now let's discuss the hormones. The majority of hormones enter saliva by passive diffusion along a concentration gradient across the acinar cells of the salivary gland. Such hormones are lipid-soluble, that's steroids. Salivary levels may represent the free or non-protein bound hormone levels. Cortisol levels, for example, correlate well with serum levels and may represent 10% of the unbound plasma concentration. However, cortisol may undergo metabolism in the salivary gland to cortisone, which may have implications for the specificity of the analytical process. Salivary testosterone also correlates well with the serum levels and may be useful test in research on male hypogonadism or in sports medicine. Next, biochemical test exogenous analytes. The presence of a drug in saliva is influenced by the physicochemical characteristics of the drug molecule. Passive diffusion of small non-ionized molecules is the major mechanism by which a drug will appear in saliva. Since binding proteins do not cross the membrane due to their size, only the unbound fraction of the drug in the serum is available for diffusion into the saliva. However, this is usually the pharmacologically active fraction. The correlation of blood and serum levels with saliva levels differs depending on the structure of the drug. For acidic drugs, the equilibrium favors blood, while the basic drugs are found in higher levels in saliva. Oral fluid has been seen as a non-invasive alternative to blood, but also as an alternative to urine when substitution or adulteration is suspected. Saliva can be used to detect and or monitor cotinine, cannabinoids, cocaine, opioids, diazepines, amphetamines and ethanol. Ethanol is neither ionized nor protein bound and, due to its low molecular weight and lipid solubility, rapidly diffuses into the saliva. Now let's discuss analytical factors. Saliva can be collected with or without stimulation. Saliva samples should be collected after thorough mouth rinsing, centrifuged to remove debris and frozen immediately. Commercial saliva collection exists containing absorbent pads which are left in the mouth for 2 to 3 minutes. Stimulation, masticatory or gustatory, may affect the concentration of some constituents and or pH of saliva. Since this collection method lends itself to being used in an outpatient setting, it's essential that the collection procedure is standardized and explained to the patient. The preferred method for handling saliva samples before assay is to freeze them. On thawing and centrifugation, the glycoproteins precipitate out, leaving a non-viscous fluid that is easier to pipette. Samples can also be heat treated to reduce matrix effects. Dear students, now let's discuss cerebral spinal fluid. First, physiology. The cerebral spinal fluid is a clear bodily fluid that occupies the space between the arachnoid matter, meninges, and the pia mater. It constitutes the content of all intracerebral ventricles, cisterns and sulci, as well as the central canal of the spinal cord. It is formed in the choroid plexus by both filtration and active transport. In normal adults, approximately 20 milliliters is produced each hour and cerebrospinal fluid volume is 125 milliliter to 150 milliliter. Cerebrospinal fluid has multiple functions. It protects the brain from sudden change in pressure, it maintains a stable chemical environment, and it removes waste products of cerebral metabolism. Now let's discuss pathology. Afflictions of CNS causing change in the macroscopic, microscopic and chemical composition of cerebrospinal fluid are diverse, each with its own pathogenetic mechanism. Some categories of primary CNS pathology reflected in CNS analysis include hemorrhage, infections, malignancy and demyelinating disease. Hemorrhage with red blood cells in the CSF may be secondary to hypertensive intracerebral hemorrhage into ventricles, rupture of a bearing aneurysm with bleeding into the supraconoid space, extension of traumatic hematoma, bleeding from vascular malformations. Meningitis is an inflammation of the leptomeninges usually caused by infection. Infecting organisms include bacteria, viruses, fungi and parasites. Microorganisms may reach the brain by hematogenous spread or by direct extension from sinuses, accessory structures like teeth, and via peripheral nerves. Malignant tumors may shed cells into the cerebrospinal fluid. Primary tumors, for example, gliomas, may spread along the subarachnoid space. They are more common in ventricular than lumbar fluid. Metastatic and secondary tumors reach the brain by hematogenous spread and may involve parenchyma or meninges. Now let's have a look at diagnostic use. Cerebrospinal fluid can be tested for the diagnosis of a variety of neurological diseases. Cell count, levels of protein and glucose, and cell culture are the most frequently requested tests on cerebrospinal fluid, which is obtained by lumbar puncture. These parameters are helpful in the diagnosis of subarachnoid hemorrhage and central nervous system infections. More sophisticated markers such as oligoclonal bands are characteristic of an ongoing inflammatory condition, for example, multiple sclerosis. A beta-2 transferrin assay is highly specific and sensitive for the detection for cerebrospinal fluid leakage. Typical laboratory findings in viral meningitis include: the cerebrospinal fluid white blood count is usually less than 250 per microliter and almost always less than 2000 per microliter. The differential shows a predominance of lymphocytes. The cerebrospinal fluid protein concentration is typically less than 1.5 grams per liter. It has been estimated that cerebrospinal fluid protein concentration greater than 2.2 grams per liter reduces the probability of viral infection to 1% or less. The cerebrospinal fluid glucose concentration is usually more than the 50% of serum concentration, but moderately reduced values are occasionally seen with herpes simplex virus, mumps, some enteroviruses, and lymphocytic choriomeningitis virus. Typical laboratory findings in bacterial meningitis include a cerebrospinal fluid WBC count above 1000 per microliter, usually with a neutrophilic predominance, a cerebrospinal fluid protein concentration above 2.5 grams per liter, a cerebrospinal fluid glucose concentration below 2.5 mmol per liter. Note that the range of cerebrospinal fluid values in bacterial meningitis is so wide that there is a substantial overlap with the findings in viral meningitis. Lumbar puncture can also be performed to measure the intracranial pressure, which may be increased in certain types of hydrocephalus. Biochemical tests performed routinely on cerebrospinal fluid. First being protein. Proteins are largely excluded from the cerebrospinal fluid by the blood cerebrospinal fluid barrier. Proteins gaining access to the CSF primarily reach the CSF by transport within the pinocytic vesicles traversing capillary endothelial cells. The normal CSF protein concentration in adults ranges from 0.15 to 0.45 grams per liter. CSF protein concentrations in premature and term neonates normally range between 0.2 and 1.7 grams per liter. CSF protein can be falsely elevated in the presence of RBCs from the subarachnoid hemorrhage or traumatic lumbar puncture. The presence of CSF bleeding results in approximately 0.01 grams of protein per liter per 1000 RBCs per microliter. When assessing the potential effect of CSF bleeding on an elevated CSF protein concentration, the CSF protein concentration and RBC count should be performed on the same sample of CSF. Elevations in the CSF protein concentrations can occur in both infectious and non-infectious conditions, including conditions associated with the obstruction to CSF flow. CSF protein elevations may persist for weeks or months following recovery from meningitis and have little utility in assessing cure or the response to therapy. Elevated protein levels may aid in diagnosis of inflammatory conditions such as Guillain-Barré syndrome, while levels of over 1 gram per liter are often seen. Now let's discuss glucose. The glucose concentration in CSF is maintained by both facilitated transport and simple diffusion. Glucose is removed from CSF by transport across capillaries and arachnoid villi, but also is utilized by cells lining the ventricular cavities and subarachnoid spaces. As a result, it normally takes several hours for the serum glucose to equilibrate with the CSF glucose. The CSF to serum glucose ratio is approximately 0.6 in normal individuals. Ventricular CSF has a higher glucose concentration than CSF in the lumbar space by 0.33 to 1.0 mmol per liter. The CSF glucose concentration may be altered in a variety of pathologic conditions. Abnormally low CSF glucose concentrations can occur in bacterial meningitis and mycobacterial or fungal CNS infections. During recovery from meningitis, CSF glucose concentration tends to normalize more rapidly than do the CSF cell count and protein concentration. Low CSF glucose concentrations can also be observed in CNS infections due to pneumonia and non-infectious processes including malignant processes infiltrating the meninges, subarachnoid hemorrhage and CNS sarcoidosis. However, CSF glucose concentrations less than 1 mmol per liter are strongly predictive of bacterial meningitis. The CSF glucose concentration is typically normal during viral CNS infections, although exceptions have been reported in patients with meningoencephalitis due to mumps, enteroviruses, lymphocytic choriomeningitis, herpes simplex and herpes zoster viruses. The CSF to serum glucose ratio has limited utility in neonates and in patients with severe hyperglycemia. CSF glucose concentrations rarely exceed 16 mmol per liter even in patients with severe hyperglycemia. Now let's discuss other laboratory tests microscopic examination. First, color. Normal cerebrospinal fluid is clear and colorless. Both infectious and non-infectious processes can alter the appearance of the CSF. As few as 200 white blood cells or 400 red blood cells per microliter will cause CSF to appear turbid. CSF will appear grossly bloody if 6,000 RBCs per microliter is present. Now let's discuss microscopic examination. The CSF is normally acellular, although up to 5 WBCs and 5 RBCs are considered normal in adults when the CSF is sampled by lumbar puncture. Newborns, in contrast, may have up to 20 WBCs per microliter in the CSF. More than 3 polymorphonuclear leukocytes per microliter are abnormal in adults, and despite a higher total WBCs in newborns, PMNs per microliter remain low. Dear students, now let's have a look at cytology. Cytology is occasionally useful for the diagnosis of malignancy involving the CNS. Now let's have a look at gram stain. Gram staining of the CSF is an integral part of the evaluation of the patients with suspected meningitis or encephalitis. Well, dear students, I really hope you would have understood. Thank you.